Okay, welcome to the first lecture on extremity trauma. There'll be a series of these lectures. This will be the first of. Okay, in this lecture we're going to talk primarily about extremity injuries in the form of fractures, and we'll cover some basics of splinting. Okay, we'll get into we'll have a additional lecture with more advanced splinting a little bit later on, so we're just going to cover the basics in this particular lecture. Okay. So it's important to remember that maintenance of circulating blood volume, movement of air through the airways, and the mechanics of breathing, and then the appropriate treatment of shock always comes before splinting any fracture. Okay. The only time you're going to worry about a fracture first before you do anything else is if you have exsanguinating bleeding from that fracture. So if you've got massive bleeding from a fracture, you're going to want to try and stop that bleeding first, and then go directly back to your primary survey. First complete your primary survey, and then once you're done with your primary survey, then go ahead and treat the fracture with a splint. Okay, so never splint a fracture before you've ticked off all the reversible causes of death. Right. The most severe thing you can expect from a fracture, if that's not bleeding or that's not exsanguinating, is injuries to nerves and vessels that surround the hands and feet. But those are really the only things you need to worry about with fractures, other than obviously exsanguinating bleeding, which will need to be stopped before you do anything else. Right. So distorted or wounded extremities must not distract from life-threatening injuries, as we've just discussed. Fractures are pretty easy to identify. They may be disabling, but are rarely immediately life-threatening. Okay? And then once again, unless exsanguinating, then the extremity trauma becomes the first priority. Okay? So the potential danger here is hemorrhagic shock and neurovascular compromise, and make sure that you always check your distal pulses. Okay? So if you've got distal pulse, you're good to go. Right? You want to then go ahead and splint, bind as you find. Good. So there's two different types of fractures. You get the open or the compound fracture. Compound fracture is when you have communication with the outside world. So it constitutes a risk for infection. So you want to make sure that you rinse that bone fragment before you fracture it, and make sure that you keep it as sterile as possible. Right. And you may also have blood loss as a result of that. So you have major vessels that run pretty close to the bone. As the bone exits the body, it may lacerate major vessels and it may cause bleeding. Again, if you get that exsanguinating bleeding, or if you get massive bleeding that's not controlled, you need to control that before you go ahead and do anything else. You may get closed fractures, and there's no communication with the outside world with a closed fracture, and there's really no danger of contamination here. Right? But you can have quite a significant amount of blood loss with a closed fracture, and that will be blood loss into the surrounding tissue, or into the tissue surrounding the actual fracture. So, for example, with a closed femur fracture, you can lose about 1.5 liters of blood per femur. So that if you have a bilateral femur fracture, that's 3 liters worth of blood loss, and that absolutely constitutes an emergency. Okay, so you need to be reticent of that fact. With patients like this, you're not going to treat the fracture with you're not going to treat those femur fractures with complicated splinting techniques. You're going to load that patient on a spine board, treat him for the major reversible causes of death, and then possibly sort those fractures out on your way to hospital while you're actually mobile. Okay. The other type of fracture that can cause a large amount of blood loss is the closed pelvic fracture. Okay, so you have the two main sort of blood vessels, the inferior vena cava and the aorta, that run through the pelvis and end up in the retroperitoneal space, the retroperitoneal abdomen. They can be lacerated as a result of a pelvic fracture, and obviously that constitutes a life-threatening emergency. So you're going to feel for pelvic stability. If you feel any instability in the pelvis, you want to try and splint that pelvis, and we'll talk about how to splint that pelvis a little bit later on. Okay. With each pelvic fracture, you can expect about 500 mils of blood, and often pelvic fractures you don't get pelvic fractures in isolation. So if you have one pelvic fracture, you may have 2 or 3 or 4 pelvic fractures. You don't often get a pelvis that's only fractured in one place. Okay, so keep that in mind. Pelvises bleed a lot, and they can constitute a severe emergency. Okay, so management for fractures. We can talk a little bit about splinting. Okay, so Splinting prevents motion of broken bone ends inside the body, and you can imagine if you've got nerves and you've got vessels that run pretty close to the bone, and as the bone moves around as a result of the fracture, it can lacerate those nerves, can lacerate the vessels around the actual bone, and also the tissue surrounding that bone. Okay, so it can cause additional pain. So with splinting, what you're trying to achieve is you're trying to eliminate any further damage, and you also want to try and decrease pain. Okay. With load and go patients, and when we talk about load and go patients, we're talking about patients that have a reversible cause of death that needs to be managed, or patients that need to get to hospital quickly. So that would constitute an airway problem, a breathing problem, or a bleeding problem. You want to try and sort those out. Get your patients onto a spine board, sort out the major reversible causes of death, start transportation, and once you've sorted out those major reversible causes of death, then you can go ahead and do some splinting during transportation. So don't get distracted by splinting, or don't get sucked up or sucked into splinting when your patient's busy dying of an airway problem. Okay, so splinting rules. You want to adequately visualize. So remember, we spoke about getting your patients trauma nude. So if you can't see it, you can't treat it. So you want to try and cut their clothing off. You want to make sure that your patient has a distal pulse before you go and put a splint on. And then once you've splinted, you want to go ahead and make sure that your patient has a distal pulse. Okay. If your patient has a distal pulse before you splint, and then you splint the patient and they lose a distal pulse, you're now compromising that limb. So you need to take that splint off. Sort of reposition the patient's or the fractured limb, and then go ahead and splint it again. We're trying to keep that distal pulse. Make sure that you've always got that distal pulse. When you splint, you want to immobilize one joint above and one joint below the fracture. Okay. So apply the splint away from an open wound. You want to pad the splint well, so that's for comfort purposes. Splints often have sharp or hard bits that will stick to the skin, and this could cause pressure injuries. All right, so make sure that you've padded your splints correctly, and whatever you do, if you have an open fracture or a compound fracture, don't go and try and push the bone ends back under the skin. Okay, you're just exacerbating the problem. You're exacerbating the chances of infection, so don't do that. Make sure that you cover the bone. You can first rinse it, then cover it with a moist dressing, and then go ahead and splint to transport the patient to hospital. Okay, so if in doubt of any injury, if you're not sure if it's fractured or if it's just a sprain or a strain, you want to go ahead and splint. So splinting is important. Nobody's ever going to be angry with you if you splint a limb that isn't broken. Use it as a precaution and go ahead and splint. But again, just make sure that you first ticked off all those reversible causes of death before you start splinting limbs. Okay. A couple of different types of splints. So you get the rigid splint. This should be padded very well. Like I said, you want to avoid pressure injuries. And should always extend one joint above and one joint below the fracture. You can also find soft splints. Okay, so soft splints such as air splints are good for fractures, but air splints have a couple of limitations. For example, they apply pressure. They'll also straighten the limb as you apply the splint. So if you have a limb that's deformed, when you apply the splint, it's going to straighten that limb out. And you want to try and make sure that you have those distal pulses before and after you actually apply the splint. As well, the air splint can cause a little bit of, it will cause enough pressure to decrease blood flow to the limb, so that could be a bit of an issue. It's not a huge issue, but it is something that could be a problem. And then obviously if you're using a air splint in sort of extreme environments, so if you have extreme temperatures, that may cause deflation and inflation of the splint based on those temperatures, and also if you have fluctuations in pressure. So if you're working in the aeromedical environment, if you apply a air splint, obviously as air pressure decreases as you gain altitude, the splint is obviously going to become tighter and tighter and tighter. So that's something to keep in mind. Right. Then you have the traction splint. The traction splint is designed primarily for the fractures of the femur. It holds the fracture immobile by applying a steady pull of the ankle while you apply counter traction to the ischium, which is within the groin area. The steady traction overcomes the tendency of a very strong thigh muscle to spasm. Okay. If traction is not applied, pain will worsen, and because bone ends tend to impact or override, so impacting means the bones will impact together, or if they're not aligned, they'll override, so the bones will override, and this will cause quite a lot of pain for the patient. All right, we'll discuss traction splinting a little bit later on when we discuss the more advanced sort of splinting techniques. And I just want to raise a point here. Whenever you're going to splint a patient, make sure that you provide pain relief before you actually splint anything. You have pain relief, use it. It's criminal not to use pain relief on a patient before you splint a limb. Okay? It's not criminal as in technically criminal, it's just a figure of speech, but it should be a criminal offence. Not giving your patient pain relief when you have pain relief available. Okay, it's very painful to splint a limb because obviously there's a lot of manipulation of that leg or that arm that you're trying to splint, and it causes that bone to move around. It's going to lacerate tissue, it's going to lacerate vessels, it's going to lacerate nerves. So there's a huge amount of pain for those patients. Go ahead and use your pain relief. Okay. This brings to the end the first lecture on extremity trauma, and there will be a series of these. We'll discuss some of the more intricate extremity traumas going forward.